Well, great. Good afternoon and welcome on behalf of our entire team. This is our Improving Access to Quality Medical Care webinar series, and it's done in partnership with the Southwest Telehealth Resource Center, the Arizona Telemedicine Program, and the Arizona Department of Health Services. You can go ahead and go to the next slide, please. We'd like to begin with this beautiful land acknowledgement. We respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through our educational offerings, partnerships, and community service. So welcome. On behalf of the SWTRC, we would like to welcome everyone in our region that includes Arizona, Utah, Colorado, New Mexico, and Nevada, our fellow HRSA grantees, and all other participants. The Arizona Department of Health Services, the Arizona Telemedicine Program, and the Southwest Telehealth Resource Center all welcome you to this free series. And we really do hope that you'll find this helpful and work with us to spread the word that telemedicine can help you achieve these goals by improving quality, safety, efficiency, and access to care. A few hot tips and notes. Your phone and/or computer was muted. We really do want to interact with you. We would like to please use the chat function to ask questions. We'll ask questions as we go along. Please fill out our post-webinar survey. We would like to know what other hot topics you would appreciate and appreciate your feedback. The webinar is being recorded, and the recordings will be posted on our website along with the PDF. It'll be the gift that keeps giving. And now I would like to welcome our guru, our billing CPT expert, Carol Yarbrough, who just makes this sound so simple and fun. It's just, you make this such a pleasure. It's truly a gift. You're an amazing resource to share because this is just such complicated work that has to be done with regards to those critical skills. And what I'd like to do is first share just a little bit about Carol. She's a healthcare compliance and reimbursement specialist. She provides a unique background in legal technology, revenue management, clinic management, both with federal and state regulations. And for the past 6 years, she's actively contributed to telehealth initiatives at UC Health. She works hands-on with professional fee and hospital-based fee professionals to implement billing strategies and provides real-time feedback to clinicians regarding documentation and staffs with their encounter guidance. She also trains CPT coding professionals at the UC Medical Center in order to maximize EMR workflow with greater documentation and coding. What a valuable skill. Welcome, Carol. Thank you so much for joining us today.
Thank you, Janet, and thank you, the ATP and everyone who's joined us, all 197 of yous. So first, the disclaimer. I have opinions. Sometimes they come out. So the opinions expressed in this presentation are mine, not necessarily those of the ATP or Arizona State U or anyone else. They don't guarantee the accuracy or reliability of the information provided herein. I hope to provide the accuracy and reliability thanks to like all my citations from CMS. My dogs have their own opinions, particularly about FedEx, UPS, and USPS. They may contribute to the content of today's webinar. I shall leap for the mute button when the postman shows up because he brings them treats and it gets really loud. Okay, so our objectives for today. One, how everything old is new to CMS. Learn about this new split shared update to critical care, another modifier. Learn about critical care, the global period following a procedure. It's another modifier. And how this may affect tele-critical care services. It may, particularly during the PHE, public health emergency. So what's old? I'm old after the last 2 years and reading the Medicare physician fee schedule for this year. Okay. What's old? The definition did not change. 99291 is the same old thing. It's you have to document at least 30 to 74 minutes in order to bill 99291. No coder likes to see 30 minutes on every single critical care note. Please put at least 33, 35, 40, anything that's not 30. Codify, which is I'm endorsing it, but I'm not being paid to endorse it. Codify is the APC's online CPT referral guide. And I copied this from their website as opposed to the AMA CPT book, which I do not have online, but these are the definitions from the AMA. So anyway, the services include treatment of vital organ failure, prevention of further life-threatening conditions. So you're going to treat it or you're going to try to prevent it. So patient might be stable, but your prevention is stopping it from failing. So it doesn't have to be crisis. It doesn't have to be emergency. It's forethought, training, all that stuff. The following 3 criteria, it says must be met, but the first 2 definitely. The severity needs to be documented and the time spent. Without those 2 things, you're not going to get that 99291. Proper documentation showing the medical necessity kind of goes along with the severity of illness and intensity and time. So if you state, I treated this patient for a gunshot wound, 35 minutes. It's not gonna do it for me, man. Okay. So usually it's in a critical care area, but not necessarily. It could be anywhere, usually in a facility. Okay, 75 minutes and beyond. So you get over that first 74 minutes. And why they say 75 is that it's like 99291 is a 60-minute code, right? So for time-based codes for CMS, you have to do at least half of it to be able to bill. So over half is what we like, 31 minutes. You're going to get that 99291. So why does this say 75 and beyond? Because up to 74 minutes, that's 60 minutes plus 14. That's still a 99291. But once you get over that halfway mark, 75, 76, you get to bill the additional add-on code of 99292. 30-minute blocks of time. You can bill up to 2 or 3 if you had to. I mean, I'm sure there's a medically unlikely edit. I rarely see 99292 in auditing or coding, but it happens. And then, of course, every coder's like 74 plus 10 plus, just anything to get that mental stimulation. Couple of cool things. If you report 74 minutes on one date, you're only going to do the 99291. So it's 11:59. You've reached 74 minutes. At 12 o'clock on the next day, you got to do another 60 minutes or additional 75. Get it? So 1 24-hour period. Day, not 24 hours, but 24 hours in one day, calendar day. Okay, critical care in the ER. Usually, if you're an ED doctor, the ED codes, the 99281 through 99285, these are not time-based codes. These are urgency. They are what you've done, what you've reviewed. It's old school. No time. Usually you don't get to report those with your 99291. It's either or, because the 99285 doesn't have any time associated with it. But say, during the patient comes in, you do a 99285, maybe an hour or two passes while the patient's waiting to be admitted and they're still in the ED. They decompensate. You can start the time for critical care then. Some payers would like modifier 25 to go on that 99285. Oh, people are going to be questioning me about that. And then also, if you're billing a 99291, 99292, and you're doing procedures that are not bundled into that critical care package, and I'll list them out. It's a nice little chart. You put the 25 modifier, which means separately reportable procedure. So that's going to be the 99291, which gets the 25, not the procedure. Not the procedure. It's separately identifiable. Got that on the 10 commandments of coding critical care. It's got to be right. Okay. We all care about documentation. It's like a contract. If it's not in the contract, it's not part of the deal. Same goes with presenting documentation to an auditor, to another provider, to the patient. If you didn't document it, you didn't do it. So each separate physician document is like a little mini contract to the payer. It's not like an inpatient admission where you've got 7 days that are the full contract with your addenda and your indices and what happened and this, that, and the other, and medication lists. For physicians, every day is its own entity. So we're only paying attention to what's on that one piece of paper, as crazy as it seems. So include organ system, interventions, why you did it. Can't intubate somebody just because it's going to make it a critical care service. Critical findings of lab tests. We would love that as coders. Some coders can read lab results. I've chosen to not. Personal choice. Plus, I'm not tempted to try to put meaning into a note that the doctor did not document. Okay. Course of treatment. And what is that life-threatening deterioration without intervention? Patient's going to lose their leg if I didn't treat the gangrene on the toe or whatever. It's not life-threatening. You know what I mean. Here is a super cool checklist that I borrowed from R1 Consulting. I am not telling everyone to go out and consult with this company, but I was lucky enough to attend their critical care update webinar last week, and they sent out the PowerPoint. And so I borrowed this. Great people based in Chicago, near my hometown. But this checklist does support everything that you should put in the document that's going to help your coder understand how critical the care was that you provided. Please put this. I spent a total of X minutes providing critical care services. Now, if you put that statement and there's nothing like hypovolemic or shock or whatever going on in the note, then maybe if it's an inpatient progress note, we can use that time documented on the floor as admission of time, like 40 minutes, but there was nothing intensive about the note. That could qualify as a 99233. Criteria, again, withdrawal of the ventilator, patient would die. Examples of treatment, thrombolytics, antiarrhythmics. Always think of eurythmics. Love antiolenics. Epinephrine, all this stuff, Narcan, mechanical ventilation, CPAP, BiPAP, or ETT. Let me go to the next slide. Examples of failure. That looks dire, right? Take any one of these things out, and that is not a happy patient. So what is bundled? I didn't put the CPT codes in, but this will help kind of, I don't know. As I tell people, I have a degree in English, so I tend to think in pictures when I read as opposed to like a translation. So cardiac output measurements, okay, you can visualize, blipping and beeping, and chest x-ray interpretation. You don't get to bill extra because you looked at the chest x-ray. It's all included in what you did to treat the patient during that hour or that 35 minutes. Pulse ox, it's always bundled. Never bill pulse ox separately unless you've sent the patient home with a pulse ox and you're doing remote physiological monitoring. Arterial blood gas, EKG, gastric, transcutaneous pacing, ventilator management, all this stuff, all part of it. You don't get to bill extra. And then, so it's time per 24-hour day, calendar day, not like 6 p.m. to 6 p.m. the next day. It's a calendar day. So it includes a time when you're in the space doing something else, perhaps, that is going to affect staving off the criticality of that patient's life. It includes whatever you've done in that location. It includes time for those bundled services that I just mentioned. You might not have done it, but that time is kind of padded out because these are sort of normal things that happen when you're providing critical care. And then if you've done an endotrach intubation for airway 31,500, you don't get to count that in the time because it's separately reportable. It's clear as day. I'm looking at, let's see, let me take a quick break. Let's see. Oh, Nancy. Okay. You guys, all right. So CPT codes, common procedural terminology. Even that sounds boring. That's why probably it's shortened to CPT because that sounds kind of fun. CPT. These are the codes. And there are age delineations. Above 5 years. There's the time. Now look at the total facility. Okay, say you're in a non-facility. Where would you do critical care? Okay, so you're in a non-facility. You're in your physician clinic, you doctor, provider, NP person, and all of a sudden your patient just crashes. Like, what's going on? You're going to get 8.11 total RVUs. And these are the national RVUs. Depending on your geographic location, you'll either get percentages above or slight percentages below that total figure. In a facility, the physician alone is going to get 6.33 RVUs. I should have looked, but I can't imagine, like even a cornea transplant or whatever, cataract surgery. I think that's still only like, how many RVUs is that? Somebody tell me. It's not as much. It's just not as much. Okay, I've been coding pediatrics lately. because I can't say no to anyone about anything. So 28 days or younger, 24, look at this, 26 RVUs, because these are per day codes, because you're constantly hovering around neonates in the NICU. These are also full day. And then here are telehealth consult codes, 60 minutes, each additional 50. So I guess, you know, over the halfway mark for the first one, and then half of 50 for the next one, 26 minutes on top of 60. Somebody add that up. I'm not going to do it. I'm on camera. It's pressure. All right. Now that we've seen those RVUs, the totals, let's talk about the conversion factor for 2022. We're really getting to the good stuff. Don't worry, bear with me. It's all groundwork. It's all paving. Conversion factor for 2022 is going to change 2 more times this year because of sequestration. So we're starting off with $34.61. When the sequestration and reduction in RVU conversion rate factor was halted because of the public health emergency, the CARES Act halted that through March 31st, 2022. So it's today's, I don't know how many days are in February this year, but it's like in less than 30 days, another cut's coming. So effective April 1st, there's going to be 1% of that $34. It might, I don't know, every penny is worth something. And then the Band-Aid will be fully peeled off on July 1st, and the entire 2% will be applied in line with the CARES Act legislation. So I guess if you're thinking about, wow, I'm going to get 8.11 for that critical care patient I had times $34. And then you forget, like, say July 2nd, you're like, wow, I'm going to get that same amount of money for all that care I gave to that patient. You're not, you're going to get 2% less. So again, this is just the same info, but in a copy pastable format. All right, qualifying conditions for critical care: ventilator, hypoxia. I like those hypo words. They're great for coders to say, oh, hypotension, hypo. That means it's bad. Hypoxic, hyponatremia. This is all critical. Non-critical care, dermatologist treats a rash for someone who is critically ill, but the rash is not yet critical. And you wouldn't be able to bill for it if the rash got even worse due to the ventilator rubbing or whatever, because that's a hospital obtained condition. Yeah. Post-op, ICU for monitoring. You see that a lot for cardiology patients. It's just pain and meds. So if something turns critical, then you can bill critical care, but they're not critical. They're stable and they're being monitored. All right, so for telehealth consults, the key word is consult. You're doing it via telehealth, like neurostroke has been the only instance I have encountered. Stated reason to substantiate need for service. Patient has a droopy right-sided face. I would like to know if I need to administer TPA. So during your synchronous audio-visual interaction, hey, patient needs TPA, da-da-da. And then you got to document it and get it somehow back to the requesting facility or ED into their EMR. Without a report back, consultation hasn't occurred. Additional documentation required, a lot less than where you are performing critical care. it's less for a consult. Now, during the PHE, the public health emergency, where we're being allowed to do 99291, this is an attending, instructing someone to do something because they cannot go into that room due to PPE constraints, due to not being there in person, but remote due to their own illness, but only that person's knowledge can instruct that person to perform that life-saving intervention. So that's why 99291 was allowed during the PHE, and afterwards it won't be. All right, what's new? All right, so it's finally what you guys came for. The definition was removed May 9th. Noticed it with a friend of mine. We're like, wait a minute, critical care, let's look at the CMS definition, and it was gone. They had then sent out an announcement a couple of days later and said, hey, we removed it because we put our own kind of paraphrased definition of what critical care enacted. And by paraphrasing, they're sort of giving billing advice. And what Medicare does not want to do is give billing advice or documentation advice, really, in the online manual. So they put it back in. They adopted the AMA's prefatory language in what constitutes critical care. And then they embellished it. Because it seemed like they were going to take away things that we didn't want taken away, like concurrent care of different specialties. So the rule did say at one point that critical care could only be done by one provider per day. Everyone was like, but wait, I'm a cardiologist, I'm a neurologist, I'm doing this stuff. And they were like, oh yeah, right. So it can be done within that 24-hour day, or even at the same time, same patient. There you go. And it includes a nurse practitioner. And then regardless of group affiliation, that was another thing. If all the physicians are in the same group, only one person could do it. Well, that doesn't make sense. If you're in a billing group that takes care of a bunch of different specialties, you know, you're a cardiologist and your friend, Joe, neurologist, also does critical care, then they were going to say only one of those specialties can do it. They're saying now, okay, even if you're in the same billing or medical group, you need to prove that it's not duplicative. Usually it means it's going to lead with a different diagnosis code on the billing. Okay, split. All right. Split shared. Caring is sharing. No, sharing is caring. So, but this really isn't sharing the fruits of labor. It's what's happening is for shared visits, which can only take place in a facility, not in a physician office. That's the land of incident 2. But in a facility, there is going to be one billing practitioner. And then the other person doesn't get any billing. So there'd have to be some kind of back-end agreement that you're going to share the RVUs or the money that comes in. So the split visit is with a nurse practitioner in your billing group, in your specialty. The joint time is counted once. You can't say, well, my nurse practitioner was there and I was there. So if you add the time together, it's an hour's worth of provider time. Now, even though they said it can be concurrent with other specialties, it can't be concurrent to add time together that took place at the same, during the same duration. So this is consistent for all split or shared, It's consistent with the E&M guidelines. So only one individual is counted during a certain time period. NP can do critical life-saving care. Then the provider, the MD can come in, or the DO can come in and do up more life-saving care. You can add that time together. You don't have to document start and stop, but if you're documenting in the EMR and you're entering data here, and then someone else is entering data here, you can kind of tie together when things happen in a day if you were an auditor. Let's see. You have to identify the other practitioners that took place during that shared event, if you're adding the time up together. And I think this is the next slide. Okay. The role, kind of restates what I just said. It's all about medical reviewers. We're simple people. We need things spelled out. And this is just showing that it could not be shared before, but now it can. I'm going somewhere with this. Yeah, it's now legit. Yay. But bad for coders because now we have to sort through more stuff. So again, facility only. The advanced practitioner must be in the same medical group with the MD. You have to be in the same specialty, and you cannot split shared for someone who's employed by the facility. A lot of places have nurse practitioners that are employees of the medical center, but not in the medical group. So you can't do that because you're double billing the time again, because the facility is already putting the NP's time on the cost report and billing Medicare for that time, that expense that they pay for that salaried employee. All right. I was going somewhere with this. Okay. For split shared visits in facility settings and split or shared critical care visits, you're going to use FS modifier. Non-facilities, don't do it. Just don't do it. But for facilities, if the medical group is employing that nurse practitioner, that advanced care provider, and the MD, add the time together. And you put a modifier FS on there so that CMS knows who to audit when it comes back to it. All right, let me get back to the point I was going to make. 1233. Okay. If a nurse practitioner sees the patient for 45 minutes, and then, so that's 45 minutes out of the hour, let's say 47. And then the MD does their 15 minutes. You do not get to bill under the MD, who will collect 100% of the reimbursement for that activity. You will bill it under the nurse practitioner's NPI, and you will get reimbursed 15% less. You get 85% of what an MD gets. Whoever does the preponderance of documentation and work must submit the bill. Okay. FT. Let's see, question. Let's see. Oh, Janice. Hey, Janice. Okay, so FT, critical care updates for a patient in a global surgical period. You do a hernia surgery on your patient, and then the same patient, and you're the surgeon, something else happens, and you have to ventilate the patient, not as a result of the surgery, but maybe they had a COVID positive PCR, and after that surgery, they were affected by COVID and had to be ventilated. I don't know that a surgeon, yeah, sure, a surgeon would intubate and ventilate the patient. Use an FT modifier as long as it's not something related to that hernia surgery, which is a 90-day global, which means all your follow-up care when you go back to see your surgeon, they are going to not bill you until day 91 for any other follow-up care. So there's two modifiers, FS, facility split, mnemonics, FT, global surgical period, facility, I don't know, I can't think of one. All right. So that really is the split shared thing with the FS. It's boggling the minds of people working in EMRs how to, I want to say, make sure that that modifier gets onto that encounter. Indicate that the provider doing the preponderance of care is the billing provider, and then the service provider. So you've got your billing provider is going to be the NP, say, and the service provider is going to be the MD. Whereas before, it always seemed like the MD is the billing provider and the service provider is the NP. Because there was really no way to tell if it was split shared before, right? Because if you're in the same group, it's not incident 2, but that NP, when doing shared visits, that's how the 1500 would look, like a sandwich. Hungry. Records, looking for FS, and look for aberrations. Like maybe, sorry if I glitched out a little bit there. Maybe you kept billing the same way, but put FS on there, and you got paid 100% for services you should have gotten 85% for. They're going to take that money back and extrapolate it depending on how many NPs you have in your practice and for how many years. Since this is new, get it right now. It's only February 22nd. And so you'll be able to set yourself up for success. Okay, so if you're wondering about place of service 10, this is the deal. I'm leaving critical care behind now. This is just an afterthought. And I'll be finished. Yeah, okay, we got questions. That'll come at the end. Okay, so the definitions for place of service codes changed. So O2 is place of service for reporting telehealth services rendered by a physician or practitioner from a distance site. 10 is for telehealth services provided in a patient's home. 10 is going to be primarily related to ESRD, people doing home dialysis, substance use disorder, and behavioral health. Because with the new law that came out this year, any behavioral health service, as long as you've had an in-person, once the PHE is over, this is the deal after the PHE. You onboard a new patient. Within the next 6 months, you have to see that patient for your first telehealth visit. And then you can just see that patient anytime at all. The requirement is that that patient comes in for once a year in-person visit to the clinic. This has been criticized. It's not really speaking to what telehealth really is. Probably it's related to the fact that behavioral health can also be done audio only now as well. And if it's audio only, you put an FQ modifier on there. FQ is only for behavioral health. I didn't put this in the deck, but there is the new audio only modifier 93 that was created by the AMA. For instance, Medi-Cal in California just adopted 93 for audio only. I know in Arizona, it's UD. I tried to persuade the Medi-Cal folks to be like Arizona, but they went with AMA. Some private payers immediately adopted Place of Service 10 and didn't really care what the service was. They said, if the patient's at home, put a 10 on it. The Place of Service listing said that it was effective January 1st, but available to Medicare April 1st. I don't think they're going to ask you to back bill anything for behavioral health because we're still under the public health emergency. Guidance will come out. I have not seen anything. If anyone else has seen anything, let me know. Let me get to the next slide. There we go. All right. This was my question I asked during the webinar last week for R1, and a delightful coding manager named Stephanie answered me. So shout out to Stephanie. Does the shared split extend to G0508 and G0509 or just 99291, 99292? And I think I was saying during the PHE, because we can't bill telehealth 99291 after the PHE is over. So the codes apply to these codes only. 99221, 99231, 99291. Emergency department is still split shared. Now the substantive portion rule, I don't know, if the NP documents chief complaint, the HPI, all the PFSH, the PE, a bit of the MDM, and then the MD documents, there are additional comments about MDM, as long as the MD and the NP are in the same specialty, paid by the same people. The bill would go out under the NP's NPI, get reimbursed at 85%. Here are the resources for this particular deck. And now I will be so happy to answer questions.
And we have some great questions.
Oh, good.
But the first question is a great comment. Carol is a rock star. Yes, yes, yes. Yes, she is. And let me go ahead and read through a few of these for you because we absolutely have some very specific ones that I know you'll be able to answer. First one, Carol, do we need to include time to read email messages from the patient or their care providers prior to the visit as part of the visit? The review of past medical records, documentation, and coordination of care is all we have included in the visit time, is the question.
Something, this is for the 2021 guidelines. Yeah, include that in there. It's review of records, it's review of communications. And so go ahead and add that time in there, document it, what you did, and you're golden.
Perfect. In a shared office visit, eating disorder, patient needing joint visit for decision-making with a psychotherapist in their separate office and a dietitian in their office, patient with their family at home. Can both providers bill for the full visit time?
You may only bill for the time that you were separately providing advice and interacting with the patient, or you would bill it based on the medical decision-making portion. Psychologist, maybe with the nutritionist, might want to bill a time-based behavioral health code. So you would want to document your at least, okay, most of them are 30 minutes. So I guess document your 25 minutes or your 20 minutes where you were actively, not concurrently providing advice to that patient at the same time as the other billing provider. In the documentation, you should mention the other person was there and you did not include their time. The time was not concurrent with the other provider.
Good note. So it's the time that you're spending on the topic that you're treating.
Yeah.
By preponderance of work in critical care, you mean by time only, correct?
Yes.
Okay. And yes, today's webinar is recorded and the PDF is there. Let's see, what would the place of service be if the location of one facility is non-medical, doing UAs and pregnancy tests by an NP?
It's non-medical and the NP is on the site doing the ultrasound.
We may need more information for that one.
Yeah.
This is from Samantha. What would the place of service be if the location of one facility is non-medical, doing UAs and pregnancy tests by an NP? Well, maybe you can give us more information in chat for that one, Samantha. Could you please explain why the MD would be the service provider and NPP as the billing?
Because it's based on if they've done, whoever did the most work. That's it.
And that answers the next question, I believe. Suppose the provider who does most of the documentation is not the provider who did most of the work. Make one an MD and the other an MP, and whose rate applies?
You should only be documenting your own work. You cannot attest to someone else's work. You cannot scribe if you are a medical provider for a medical provider, because your own biases are going to go in there. I would suggest that if you are going to do the documentation, then you should only do it based on time. Like, I didn't hear there, someone else is documenting, but you know, just be truthful, mark out who did what during the interaction. Yeah.
Good answer. In person once a year, is this only for mental health and not for other subspecialties?
True.
True. What is considered a distant site for point of service O2? POS O2, I shouldn't say that.
Yeah, distant site is being away from the patient. So the distant site can be a provider's home. Distant site can be a clinic. But the guidance that we had from CMS prior to the public health emergency was if your provider is 100% at home, then you have to register that home address as a place of service. But you know, the question I have, and people should comment on this, is say you're okay, so we determined I'm not a clinic, right? Like my house is not a clinic. But if I'm doing remote patient monitoring, RPM, and I'm reviewing stuff, and I'm a doctor hired by a company, and we're doing our own billing, what place of service do I put? RPM is not telehealth. It's communication technology. I mean, it's an evaluation and management code, but it doesn't require face-to-face. And there does have to be one synchronous audio or visual interaction. So if anyone has thoughts about what place of service to put on that, I'd appreciate that.
Boy, it just hurts thinking about this stuff. I'll say, please confirm these next two comments and maybe comment on the comments. Arizona Medicaid is now FQ. UD was end dated 12/31/2021.
Oh, excellent. Okay.
FQ just states that the service was furnished using audio-only communication technology, and this is for Arizona Medicaid only.
Okay. So maybe
Okay.
they'll move it to 93 since FQ is supposed to be for behavioral health. They didn't explain that. CMS didn't really explain that until mid-December.
Well, you received, before the next couple of questions, a couple of great thank yous and a confirmation that you, yes, indeed, are a rock star. Review of records, labs, etc., can only be counted on the DOS seeing the patient.
So if you spent on a separate day of service over 31 minutes in review of labs, etc., put a phone call in maybe to another provider to ask about something else, you may document 99358 the day before the visit. Cannot bill it on the same day anymore because now we have prolonged care codes for day of for non-face-to-face, but non-face-to-face on not day of. You may document your time, just let your coder decide if it was enough. Actually, I play the French horn, so I don't know if that would qualify me in terms of rock arenas unless I was in the Who or something. Yeah, so go ahead and check out the definitions of 99358, document that day of, document in the documentation that it is in relation to preparing for visit in the future, or if you got records on that day of, you didn't have time to prepare, you can do it the day after, 2 days after, and refer back to the day you saw the patient. It's got to be in relation to face-to-face visit.
And the French horn is very difficult to play, so I'm still going with Rockstar. Yeah. If patient is improving on mechanical ventilator and is requiring a lower level of oxygen support from that mechanical level, is it still critical care? Also, when the patient is on a mechanical ventilator and a weaning trial is undergoing, is it still considered critical care?
Depends on what else is going on. If they were fully taken off of that ventilator and they would decompensate, they would suffer, that would be critical care. Yeah, Nancy says, yeah, because it could go south.
Well, we're going to rip through these questions. If a medical provider is addressing a mental health diagnosis, is this coded as behavioral health service, and is it available for POS 10?
If a medical provider provides behavioral health, there is a CPT code 90791, which is behavioral health with medical service. So that's if you're going to prescribe medication or something like that. You're making medical decision making and not counseling. So yeah, you can use that.
If you are a telehealth consultant in states in which you are licensed for patients in multiple states.
It's 90792. Thanks, John. Sorry.
Oh, there you go.
Okay.
I find this confusing, but maybe it makes sense. All of this is confusing to me. If you're a telehealth consultant in states in which you are licensed for patients in multiple states, do you need an office in multiple states in order to bill, or just one state?
Just one state, but any billing that you do to Medicare has to go to the MAC that oversees your state where you live. So you have to register your billing office, even if they're in a different state, has to register you with the MAC where you're practicing. Everything used to be all about all about where the patient was. Now it seems to be like, we don't want people to game the geographic practice location benefits. Like, I'm in San Francisco. I think the Gypsy is like 1.15 or whatever percentage points. Maybe Texas is below 0.1, maybe it's 0.95. So I shouldn't get paid, even though my patients in California and San Francisco, I shouldn't get paid where I'm sitting because my overhead isn't as expensive. I don't know. It's the office in San Francisco is still incurring costs of FTE and overhead for whatever, but that's what they want right currently. Okay.
How do you perceive, and maybe this was already answered, 99238, 99239, and also 99217 to be adjusted based on these new split share rules? They have a time-based definition. However, 99217 has no similar definition to time or MDM requirements.
Go ahead and check the 99217s and then the G22. John should answer that for me. Now he's my coding person on the chat. But whenever Medicare wants for whenever Medicare wants for that prolonged, oh, the neighbor's here. Oh,
is it the UPS truck?
No, he's letting us know that street cleaning's happening and we're going to get a ticket if we don't move the car.
Oh,
so at 1 o'clock, I'm torn. Where's my
well,
husband?
we're just about wrapping it up. We only have a couple of more questions, and we can send them to you, no problem.
Yeah, and I'll move the car and I'll save $75.
Yeah, okay, please do. And thank you so much. You are just amazing, absolutely a rock star, and we love having you on our team and can't thank you enough. We are here for you, and please do, everyone, complete your survey. We will get to the rest of your questions. I'll copy them and send them to Carol, and we will follow up.
And I'll answer them. All right, thanks everybody, and thanks for your forbearance. I'm just going to go run and move the car.
No worries.
Take care.
Thank you. So I would like to thank everyone on behalf of our whole team and let you know that we do want to have your opinions and your suggestions for future topics. So thanks so much for joining us. Look at all these great thanks to Carol. Really, this is priceless. This is really a great webinar. So please let folks know who missed it as well that we have it archived. Chris, did you have any closing comments?
I'd just like to add that we are doing, Janet is doing a monthly grant writing webinar that you can find on our homepage at the www.telemedicine.arizona.edu. It's a very unique webinar series where she has a didactic lecture the first Tuesday, and then on Thursday she has a pretty much a round table where people come and ask questions, and it's more of an open meeting and getting to the nitty-gritty of your specific grant that you're writing. So be sure to check those out. So thank you very much, everyone.